A very good evening to all my dear MOS members and the ophthalmic fraternity, whoever has joined today. Well, we have this monthly journal club meet. It's been going on since November 2021. Every month we are having interesting topics which are presented by one of the postgraduates, and then we have an in-depth discussion on this. I think it's the first of its kind. Any state society is doing it. Dr. Vaishal Kenia, Dr. Parul Deshpande, Dr. Sabyasachi, they were spearheading this journal club meet, and every month we have a national faculty. Today, I have my co-fellow, Dr. Vijaya, who has joined from Shankar Netralaya. We were together, we did fellowship, and we have Dr. Rajul Parikh, the state faculty, who has also joined. With us, we have the other coordinator, Dr. Sachin Agarwal and Dr. Radhika, who is going to be the main coordinators. Well, so today's topic is on the intraocular pressure elevation following intra-VEGF, anti-VEGF injections, short and long-term considerations. So wish you all the best, Dr. Radhika Savarkar. And over to you, Dr. Vaishal, for the further proceedings. And welcome Dr. Rajesh Joshi, our Honorary Secretary. Welcome all the national and the state faculty. Dr. Rahul is not there. Instead, we have Dr. Sachin and Dr. Raksha Dhanuka is also there. So over to you. Hi, Dr. L. Vijaya. Welcome to this journal club meet. And Rajul also. Yes, Vaishal.
It's my pleasure to invite Dr. L. Vijaya, Madam, and she has graciously agreed for today's journal club meeting. I'm very thankful to her. This is the first joint meeting of MOS and BOA. We are doing a journal club meeting. It's a monthly event, and we are getting a very positive response about it. And the way the whole articles are analyzed and done, and it's a lot of benefit to the postgraduates and the clinicians. So the feedback is very good, and month by month the number of attendees are increasing. So without further ado, I would ask Dr. Parul Deshpande to open the session and also introduce the coordinators and the faculty.
Thanks, Vaishal. And I welcome Dr. L. Vijaya and Dr. Rajul Parikh for this MOS session on the anti-VEGF and glaucoma. So for today, we have Dr. Radhika, who's going to present the article. And we have Dr. Raksha Dhanua and Dr. Sachin Agarwal, who will be coordinating the question answer session. Okay. I would be a part of also the coordinators, but it would be mainly Raksha and Dr. Sachin Agarwal. And with this, I think I would ask Dr. Radhika to share her slides and do the presentation.
Yeah, welcome Dr. Zain Khatib also. I think I see him.
Achha, he's yeah, Dr. Zain is there. Yeah.
Dr. Mahendra Sethi is going to join.
Dr. Sabyasachi is joined.
Yeah, he's there already.
He's the main, basically the retina side as well as the statistical side. He will be covering, sir, because I have not told Maninder this time.
Okay. No
it's
problem.
A review article, sir. So
yeah,
the comes very less, you know. So.
Fine. Nice. Sabyasachi is very good. We are so thankful that he is always available. Whenever we ask him, he is always there. Thanks, Sabyasachi. Yeah, there we are. Let us start the presentation.
Radhika, can you share your slides? I don't know whether Radhika is there. Radhika.
Welcome, Dr. Swapnesh. He is also joined.
Radhika is, I think, not connected again.
Yeah. Anybody else who can share the presentation on our behalf? Anmol, can you take over?
I'll take 2 seconds. I can. No, yeah. I can do that, sir. 1 second.
Yeah. In case you're not able to do it.
Raksha, do you have the presentation or?
Raksha is muted. Unmute yourself, Raksha.
She's sending.
Yeah, I have, ma'am.
Can you share or I?
Madam, you present the article. I think there is some problem with Dr. Radhika's thing. Just give me 1 minute.
Yeah, I've got the presentation.
She has revised it. I'm sending you immediately. Just 1
Again,
minute.
the new one?
What she did today in the morning.
She sent me one in the night yesterday. That is not, today morning she sent me. I
She
have
has
that.
joined
That is
again.
not-
Yeah, sent to you, madam.
If she can share.
Radhika is also there. I can see her, but she's muted. What is the problem is she facing? Not able to share it?
She just shared, I suppose, no?
Yeah, she just shared. We checked
Yeah.
it just now.
Yeah, we just
Anmol, if you could help technically, please. Yeah.
yeah.
Yeah,
Yeah,
yes,
sure.
fine.
Yeah,
fine.
there she has shared it. Very good. Go into the screen slideshow mode. Yeah.
Sorry for the
No,
inconvenience.
no issues. No issues. All the best.
Yeah,
Go
go
ahead.
ahead.
Good evening, everyone. I'm Dr. Radhika Savarkar, Junior Resident 3 from IGNC Nagpur. Thank you, Maharashtra Ophthalmological Society and Bombay Ophthalmologist Association for giving me this opportunity to present this article in the Journal Club. I'm here to present a review article, Intraocular Pressure Elevation following Intravitreal Anti-VEGF injections, short-term and long-term considerations. This article was archived from Journal of Glaucoma, Volume 30, December 2021. H index for the journal is 88. This study was done by Ariana Levin and Craig J. Ethel. My moderators are Dr. L. Vijaya ma'am and Dr. Raju Parikh sir. My coordinators are Dr. Parul Deshpande ma'am, Dr. Raksha Dhanuka ma'am, and Dr. Sachin Agrawal sir. Aim of the article is to discuss intraocular pressure elevation following intravitreal anti-VEGF injections, to discuss the acute and chronic sequelae of post-injection elevation, IOP elevation following intravitreal anti-VEGF injection, and also to discuss the management of post-injection intraocular pressure elevation. Eye is a closed globe which is dynamic in nature. Intraocular pressure determined by two factors, aqueous formation and aqueous outflow. Intravitreal injection was first described in 1911 to tamponade or retinal detachment. A rough estimate of about 1 lakh intravitreal injections done worldwide daily. Comorbidities like primary open-angle glaucoma in central retinal vein occlusion, branched retinal vein occlusion, neovascular age-related macular degeneration, and in diabetic patients can further complicate this rise in IOP. Recognized adverse effect of the intravitreal anti-VEGF injections is transient rise in the intraocular pressure. Despite the transient rise in intraocular pressure that may occur following injection, pre-existing glaucoma is not a contraindication to this procedure. Maximum safe volume to inject is believed to be 0.1 to 0.2 ml without pre-injection paracentesis. The most commonly used injection volume is of 0.05 ml. What is the purpose of this study? When a patient with pre-existing primary open-angle glaucoma undergoes an intravitreal anti-VEGF injection for any pathology, and post-injection patient experiences acute onset of eye pain with decline in vision, intraocular pressure is noted to be 45 mmHg, and the symptoms completely resolve without any intervention. How should this patient be managed during future injections? As intravitreal anti-VEGF injection become a more common treatment modality for various vitreoretinal diseases, there is increased concern regarding acute IOP elevation after intravitreal injections. Transient IOP spikes do not endanger visual function in healthy eyes, but there have been reports of visual field progression after IOP spikes in post-cataract surgery patients. Magnitude of post-injection intraocular pressure elevation. L. Chahab et al. In European Journal of Ophthalm in 2013 concluded that mean intraocular pressure spike of approximately 45 mmHg 1 minute after injection. Felfili et al. Proved that IOP rise of mean baseline pre-injection of approximately 15 mmHg to post-injection of approximately 40 mmHg, ranging broadly from 17 to 80 mmHg. The Varais et al. Concluded that a mean difference in IOP after anti-VEGF injection was approximately 23 mmHg immediately after injection. It becomes 2.5 mmHg at 30 minutes and it decreases by 0.63 mmHg 1 day after injection and back to baseline by 1 week. This decrease in the intraocular pressure 1 day after injection is most likely due to ciliary body inflammation, which occurs after IOP spikes after the intravitreal anti-VEGF procedure. This wide variation in the IOP spike IOP spike is most likely due to different time interval of IOP measurement and different techniques used for the measurement of IOP. Short-term intraocular pressure increase. The acute intraocular pressure elevation categorized as early, intermediate, and late. In early, the rise is occur within minutes. In intermediate, the rise lasts for hours, and in late, chronic elevation over months. The cause for immediate rise in the intraocular pressure is due to immediate increase in the intraocular volume in a relatively closed space, which can further be accentuated by scleral rigidity and hyperopic eyes. Possible mechanisms for long-term intraocular pressure increase. First is injury to the trabecular meshwork from repeated injections of high volume. Toxic effects of anti-VEGF agents itself, inflammatory damage, molecules with larger size and longer half-life in vitreous, such as bevacizumab having 149 kilodalton size, which is 3 times larger than the ranibizumab having 48 kilodalton size. Alteration in the levels of trabecular meshwork vasodilating modulators, such as nitric oxide. Anti-VEGF agents causes inhibition of nitric oxide synthase enzyme, which causes decrease in the level of nitric oxide, which causes downstream movement of the potassium and calcium in the trabecular meshwork cell, which further causes alteration of trabecular meshwork cell contractility, which ultimately decreases the aqueous outflow. Several case reports observed that acute angle closure glaucoma also related to the intravitreal anti-VEGF injections. Zhang et al. Proved that eyes with short axial length are at higher risk due to less space for the injected volume of fluid. Kim and Beck postulated that zonulopathy and mydriasis might also contribute for angle closure glaucoma. Alkin et al. Postulated that increase in the pressure in posterior segment of eye causes forward displacement of the lens iris diaphragm, resulting in shallowing of the anterior chamber. Risk factors. First is known case of glaucoma or ocular hypertension. Kim et al. Postulated that such eyes had higher post-injection spike. Axial length and lens status. Quas et al. Postulated that IOP spike reduces in pseudophakic or aphakic eyes. Protein aggregates from pre-filled syringes or silicone droplet contamination and outflow obstruction from the syringes. Agents requiring freezing, thawing procedures, or any mishandling during storage. Interval between the injections. Matholon et al. Concluded that shorter interval associated with sustained IOP elevation. And total number of injections received. Eddy et al. Did his study on 800 eyes and reported that higher incidence of glaucoma surgery in eyes receiving 7 or more injections per year. Shui et al. Did his study on 17,113 eyes, concluded that eyes receiving more injections had higher odds of initiating IOP lowering therapy or having a new diagnosis of glaucoma. Using electronic short sonography, Wen et al. Demonstrated that reduce aqueous outflow in eyes receiving greater number of injections. Brolucizumab is a long-acting anti-VEGF injection. Similar IOP spike was observed in brolucizumab also. It dosed at 12-week interval. It will be interesting to know about the long-term effect of brolucizumab on long-term IOP. It is a summary of studies evaluating risk factor for the post-injection IOP elevation. Sternfield et al. Postulated that post-capsulotomy eyes has had a higher spike of the IOP rise. Effect of injections on the retinal nerve fiber layer architecture. Retinal nerve fiber layer architecture has been found to be an important indicator of adverse effect due to pressure spike. Some studies have observed that retinal nerve fiber layer was significantly reduced at 1 year follow-up. Though Joe et al. Concluded that areas of RNFL thinning might more likely to be related to macular lesions rather than the injections. Swaminathan et al. Concluded that injected eyes with glaucoma do not have more RNFL thinning than control eyes with glaucoma. This is the summary of studies evaluating post-injection changes to RNFL. Sohelian et al. Concluded that the mean RNFL thinning decreased more in eyes without paracentesis. Various strategies have been proposed to avoid this immediate high IOP level. First is ocular decompression using a sterile cotton swab, pre-treatment with a suitable anti-glaucoma medication dosed twice daily on the day prior and on the day of injection. Oral acetazolamide 60 to 90 minutes before injection and anterior chamber paracentesis. These all graphs are not included in the main study, but just to highlight the effects, I have taken this graph from another studies. It shows the short-term changes of IOP after intravitreal anti-VEGF injections. This graph shows that the IOP immediately increases 1 minute after injection. It shows a change in mean ocular perfusion pressure after giving the intravitreal anti-VEGF injections. This shows that the mean ocular perfusion pressure suddenly decreases 1 minute after injection. This graph confirms that sudden immediate IOP spike decreases when a patient pre-treated with suitable anti-glaucoma medication compared with the placebo group, which was pre-treated with artificial tears. So to conclude, acute IOP elevation is common after intravitreal anti-VEGF injections. Chronic IOP elevation likely to occur in some eyes. Prevention of post-injection IOP spike should be considered as a part of standardized management approach. All pre-treated groups return to baseline more quickly than the control group. Pre-treatment should be routinely considered before intravitreal injections, particularly in eyes with glaucoma or known history of sustained intraocular pressure elevation. Limitations of the study: small studies might bias the data and can miss the susceptible eyes. Most published studies are indeed limited by small size and the heterogeneity of the study population. Eyes receiving a variety of different agents in a single study population limits the interpretation of results. Some retinal nerve fiber damage is already expected in some retinal pathologies, regardless of injection. So for prevention, we can reduce the total number of injections, decrease the injection volume, minimize the injections via treat and extend protocol using sustained release anti-VEGF injections to avoid repeated injections. Avoid syringes at risk of leaving particles such as silicone-free syringes. Ocular decompression with using a sterile cotton swab, and pre-treatment with topical anti-glaucoma medication if patient is a known case of glaucoma. Pre-injection workup must include angle evaluation and glaucoma workup. Intravitreal injections can result in increased IOP and cause damage. So post-procedure, IOP should be monitored and treated timely. Long-term follow-up is must to assess the RNFL architecture. I thank you my all coordinators for their guidance, Dr. Rajesh Joshi sir. I also thank you Dr. Ravi Chauhan sir, Dr. Anand Pangarkar sir, and Dr. Rahul Dagwar sir. I thank you all for your patience listening. Thank you.
Very nice presentation. Beautiful.
Raksha? Raksha, is there?
Radhika, you have done a very wonderful job, a very nice presentation. So, seeing the prevalence of anti-VEGF injections nowadays, we keep seeing that, as she mentioned, that almost 1 lakh anti-VEGF injections are given worldwide daily. So this article raises quite a number of questions. So my first question is for Vijaya madam. Madam, you are working in a tertiary eye center. So can you please share what is the incidence and prevalence of IOP spike after anti-VEGF injection in your center?
Actually, we don't have a precise prevalence of raised IOP following the anti-VEGF injections, so mainly because we don't check the intraocular pressure immediately following the injection. So only thing we follow is we never miss glaucoma in these patients, either in terms of the angle closure or pre-existing. If it is a pre-existing glaucoma, they do take an opinion. We will make sure that the patient pressures are under good control before giving the injection. So we don't give any glaucoma medications for the non-glaucoma patients whenever the injections are given. And it's always the 0.05 ml. The amount is very tiny. The same way, I think paracentesis also is not practiced routinely in our clinic. So there is some of the patients who had multiple injections, especially in the past, when some of the older generation anti-VEGF injections, we had chronic persistent glaucomas. So with the newer molecules, even that we don't see often nowadays. So I don't have the figures to share with you what exactly is the actual prevalence of glaucoma following the anti-VEGF.
Sir,
Raksha, just a minute.
Yes.
I welcome President BOA, Dr. Ragini Parekh, to the meeting. Thank you, madam, for attending the meeting.
I think you're muted, Ragini.
They are muted.
Good evening, ma'am. It is such an honor to have you. You are one of the senior most teachers and we really respect you a lot. Thank you so much, ma'am, for being here. Thank you, Doctor. Good evening, Dr. Taswala sir, and I'm so sorry to interrupt. Good evening, everybody, Parul and everybody. Vaishal, thank you. Great.
Ragini, L. Vijay is my co-fellow. We did fellowship together.
Oh, she looks much younger than you, sir. She looks much younger than you, sir.
हमें बता जूना थी क्या भाई.
Hi, Parul.
Anyway,
fine. Yeah.
Sorry to interrupt. Vaishal, please.
No problem.
I have a question to Dr. Rajul Parikh, sir. Sir, what is your say on this incidence and prevalence of IOP rise after anti-VEGF in your practice, sir?
So, Vijaya ma'am is in better position because she's in institute to get the more data. As ma'am was talking about the older, I had seen quite a few post-injection spikes after Avastin. Nowadays, people are not using Avastin much, so the incidence is much less. But I don't have figure because I'm in private practice and I see only patients refer to me who have a high IOP spikes. So So in general, if the pressure is increased little bit and is missed in by the retinal surgeon, then I would not be in position to comment. But IOP spikes is not that a big issue nowadays, and the known glaucoma patient is definitely a risk factor. The angle closure risk in the hypermetropic eye is something we have to look into. So if they have a narrow angle, those patients should be they should be very cautious. If they can do, I think pre-injection paracentesis, the risk would be much less. But again, the numbers are too small to comment about. So whatever the literature, if you read, I think they all that hypermetrop, shallow anterior chamber is high risk of developing acute angle closure, but they're case reports, not even a big series. So we cannot comment very no categorically. Okay, this is the subgroup which would have definite angle closure, but hyperop, shallow anterior chamber is anyway risk of developing angle closure. So those patients we have to be careful.
Sir, in case of narrow angle and hyperopic eyes, do you recommend, pre-injections peripheral laser iridotomy?
Definitely no, because you have to dilate and evaluate these eyes for retinal condition. So that's what I meant. You have to take care of the glaucoma part well before you give clearance for any injections. An eye that needs injection requires retinal evaluation. An eye that requires retinal evaluation requires dilatation. An eye that requires dilatation in a narrow angle requires a laser iridotomy.
So that
To
even
comment
in
a small comment, any intravitreal injection for glaucoma patients, we do request, and none of the retinal consultants also are aware, use any kind of a steroid preparation for intravitreal injection. That's the only contraindication I would think of in the present scenario in terms of anti-VEGF.
Ma'am, previously the Lucentis used to come in the pre-filled syringes. So this study, the review article is talking about silicone in the pre-filled syringes. So did you all ever see the rise of intraocular pressure following the Lucentis injections in the past? Or
very difficult. See, the review article, if you look at it very critically, the job of the group is to collect all published literature and put them in correct perspective. So they themselves have agreed it is a heterogeneous study groups, and so there is no solid concrete evidence for any of these things. So they have just gave us on a single paper what all the previous studies have talked about in terms of anti-VEGF and raised intraocular pressure. So I haven't seen any specific case to answer your question.
Thank you, ma'am.
Dr. Sachin, if you have any questions.
My question is for Vijay ma'am. Ma'am, with your vast experience, do you find any difference between this with regards to IOP rise in patients with diabetic retinopathy or for any other disorder like ARMD we are using anti-VEGF? Do you find diabetics are more predisposed to rise of IOP?
Actually, one of our fellows have looked at our raised IOP and risk factors. We couldn't get any concrete relationship. So I really don't have an answer for it. And when I had discussion with some of the senior retina colleagues, they said we don't pay attention to the transient rise in the intraocular pressure. See, even when we do a cataract surgery for a glaucoma patient, the pressure goes so high on the table using the phacoemulsification. So this all transient things. So unlikely that it will cause any permanent damage in the long run, if you ask me.
Because diabetics are more predisposed to rise of IOP or glaucoma, do you find any significant difference?
We can't say that diabetics are predisposed to glaucoma. We can't say that. We don't have evidence to say that.
Diabetes is the secondary glaucoma is separate issue, but primary glaucoma, diabetes is not a major risk factor to start with.
So do you perform paracentesis like kind of thing in patients who are known to glaucoma or susceptible to glaucoma as a routine?
No.
So we have Dr. Sengupta here, who is a retina surgeon. So Dr. Sengupta, can you give us a little, insight into intravitreal and your experience? Do you see these IOP spikes? And some comment, statistical comment on this article, if you could just highlight them.
I think first of all, I'll talk from a retina surgeon's point of view, because we do a lot of injections and the numbers are really increasing. The indications are increasing, and the number of newer drugs which are available are also increasing. So we do a lot of injection these days. And if you look at the retina literature, it says, and we know that the more the number of injections we are able to give, the better the overall visual acuity in patients. And what is recommended is generally 7 to 8 injections per year, at least in the first year. So that is so but then on the other hand, if you give that many number of injections, you're bound to see some amount of transient raised intraocular pressure. So probably there has to be a slight balance in the number of injections we give. But like Vijay ma'am has said, we really don't pay a lot of attention to transient rise in pressure. We generally call the patient back on day 1, and almost none of these patients have persistent pressure rise even for 1 day. So then it's very unlikely that it is going to have long-term effects like that. Having said that, in India, we don't really give 8-9 injections per year. Most of the retina surgeons, as hard as we try to convince patients that they need more injections, if you look at a lot of studies from India, the mean number of injections in India per year is only 3. So no wonder we are not seeing any spikes, because we are not injecting as many as we should probably. And so, the numbers are going to be much lower than what the Western literature says. So, simply logistics don't allow, or patients don't afford that many injections. So if we give more number of injections with insurance and all this coming in, we probably might see a slightly more number of patients with transient spikes. But then, long lasting, we almost never see unless patient is getting triamcinolone or, for that matter, Ozurdex. Again, there are long lasting, I think the presenter also said there are now long lasting injections like brolucizumab or port delivery systems for ranibizumab, or like the Archway trial that we discussed during the last journal club. So these are going to sort of bring down the number of injections going forward. So this probably is not really that major of a concern for most retina surgeons. Overall, like I said, even if you look at the VRSI survey, it says mean number of injections is only 5. So that's why, no wonder, even at Shankar Netralaya, I'm sure we are, most people are not getting 6, 7, 8 injections in the year. That's why, overall, we are seeing very few cases of these sorts. And like I said, it's not really a major concern for most retina or glaucoma surgeons. Coming to the overall, review. So, there are 2 major types of reviews. One is a narrative review, and another is a systematic review. And this is a prime example of a narrative review, where you're not really sure. So systematic review has a very systematic approach where there's a way in which you do a literature review, and you write the way in which your search strategies that were used, how many articles came up, how many fitted your criteria, and then how many you excluded. So if you look at a lot of these references, at least majority of them seem to be case reports, or maybe 1 or 2. And if you look at major clinical trials from retina domain, almost none of them are reporting any major glaucoma related issues over long periods of time. So, so if you exclude these, if a systematic review was done, a lot of these, these case reports would have been sort of omitted. And then you would have been left with very few articles, and most of them say it's not a major concern, isn't it? So that is what we are actually talking even from a clinical point of view. So this is a prime example of a narrative review. Narrative reviews are something which are not really, to be taken too seriously, if I might say that. So, it would have been better if the authors had tried to do a systematic review, which takes a lot of effort. This is again a very prime example of self-citations. If you look at the citations, the second author is the main author here, Malik Kahook, and he's done a lot of good work, of course. But if you see references number 3, 4, and 5, they're all his. And then there are a lot of other papers in which he's citing his own self. And, so I'm not saying this is right or wrong, it's for you to decide. But overall, ethically and somehow, we feel that self-citations of this nature or this number is probably not a great idea, where out of 30 references, 5 or 6 of them are yours, and you're the main author in the paper. So, this is something like that. And lastly, when the authors start with a case and, they sort of try to attract your attention and then, somehow lose it over the period of the article. There's so much of gibberish there, but they don't tell us what is the lacuna, what is the need for this review, or for that matter any paper. There is a need for a particular thing that we are writing. So I'm disappointed that Journal of Glaucoma is really publishing a paper like this. And even from an editorial point of view, which I have considerable experience now, I think this shouldn't have really made to the Journal of Glaucoma.
True.
I don't know whether Vidya madam agrees with me or not. She's an expert on this.
I'm your comment.
I think that the systematic review is not feasible because number of publications are not enough, as you correctly said. So they ended up with a narrative.
Okay.
Madam, I just wish to say that, or in fact ask you, as Dr. Sabyasachi just now mentioned, that we are not concerned with the short-term IOP spike. Yeah, but if a case with a 0.85 or 0.9 cupping, a diagnosed case of glaucoma is being given anti-VEGF, the patient is already on anti-glaucoma. Should we step up AGMs for that patient?
Depends upon the clinical condition, how well the glaucoma is under control. We do subject a lot of our glaucoma patients, especially with the diabetes and vein occlusion population, for intravitreal injections. We just make sure that their glaucoma is under good control. Other than that, nothing specific we have given. So what I was trying to tell you is, here 0.05 ml intravitreal we are giving. You think of any local anesthesia surgery, any vitreoretinal surgery, when they give the peribulbar, we don't know how much pressure spike happens with the peribulbar injection. By the time they give the massage and the pressure comes down, we don't know how much spike happens. So the transient spike for few seconds should not be an issue, if you ask me. But make sure that your glaucoma is under good control. If necessary, you can recommend a systemic acetazolamide rather than doing a paracentesis in such a patient.
Rajul, your comment?
I absolutely agree what ma'am said. Na? If we are really worried, then we can give for day or two short course of systemic acetazolamide rather than increasing the topical medication, because then the topical medication takes few days, before the peak effect happens. So, and then again we have to stop it, do the reverse trial. It's a more big process. The short course of acetazolamide, patient is, most of the patient would tolerate unless he has absolute contraindication. The couple of days of acetazolamide would be a better choice in high risk, not in every patient.
We don't have any role of brimonidine, so we used to, for the laser capsulotomies and this thing, we used to give brimonidine previously. So
I have never used. I don't know. I don't think Vijaya ma'am also would have used.
okay, I just asked because I think previously it used to be talked about.
I don't use even before iridotomy.
Can I make a quick comment?
Yeah.
So when we are actually practically injecting the intravitreal injection, and these patients are quite old, they have a very syneretic vitreous. When we withdraw these the needle, even if it's a 30 gauge needle, slight egress of vitreous happens. So, a lot of people mistaken it for drug which has come out, but it's not really the drug, but it's the liquid vitreous which is getting egressed. You'll see a little bleb or very transiently there, and these patients generally don't develop raised IOPs because there is an egress. But if you're worried about it and you don't see that kind of small egress or bleb-like thing, you can always think about doing a paracentesis. If it's a younger patient, he is phakic and his vitreous is not syneretic, so then you will not see any egress. And then doing a paracentesis in a dilated eye in a young patient who's phakic can also be troublesome sometimes. So, so if it's a young patient who is already having glaucoma and has a clear lens, that is where I would really be slightly worried about, because doing, I don't want a lens touch and other things. And trust me, most retina surgeons don't use a microscope while giving injections. We just use an indirect and, just finish it off. So paracentesis, and we are not used to, going tangentially. We are always used to going straight down. So we are more worried about lens touch and whatever procedures we do. So a few sort of practical tips that
I think most of the people look at the pulsations. That gives an indication about the possibility of the rise in the pressure. at the time of the injection.
Yes. Yeah. When we do an indirect, immediately after the procedure, we look at the retinal artery pulsations. If we see that, then definitely pressure is high, and we'll do a paracentesis.
Madam, in the article, they have mentioned question on RNFL analysis. Maybe if there's a short spike, RNFL may not be affected, but they have also given a confusion of RNFL defect due to macular pathologies. So in such cases where already diagnosed glaucoma cases or due to IOP spike, can we rely on the isn't rule for RNFL analysis here?
No. See, if there is a combined pathology, if the glaucoma, you mean to say in glaucoma patient or in a normal patient?
Glaucoma patient.
See, it depends upon what is the extent of the retinal damage due to the primary disease. See, if there is a retinal pathology, significant retinal pathology, that itself will affect your RNFL, especially the macular area. So you cannot depend upon just one parameter to say that it is because of the injection. How can we say that? We don't know whether the primary pathology is causing it or the transient rise in the raised intraocular pressure is causing it.
So, ma'am, is there any other indicator which can tell us whether the glaucoma is of a concern in these patients with injection? So, let's say the ganglion cell layer or any other.
I don't know. There is one study that came, they have also included, if your number of injections are more, 7 or more, then there is a possibility that this size, that is the risk factor they found for the chronic raised intraocular pressure. So probably that whatever mechanism she spoke about, the nitric oxide, the molecules and other things may be contributing. That's also is a very, very, very small percentage. So the higher the number of injections in a shorter period of time probably is a risk factor. If you ask me, that is one thing. The second thing, they make sure they don't miss the glaucoma pre-injection. So glaucoma has to be taken care. Other than these two important things, I don't see any other concern as far as anti-VEGF injections are concerned.
Sir, other than narrow angle glaucoma patients and patients with short axial length, any other type of secondary glaucoma where we should be cautious enough before giving anti-VEGF injections?
Raju, can you answer me?
So the angle closure is definitely an issue. Otherwise, I don't think that any other specific reasons from glaucoma point of view, other than for definite glaucoma, open angle glaucoma, I don't think there is any other specific criteria or any other specific category we have to look into it before we. If the injection is required, then it's required, and most of the secondary glaucoma would not be an issue.
I think one important type of glaucoma, which is at least I have missed a couple of cases, is vein occlusions, especially central retinal vein occlusion. We know POAG is a risk factor for CRVO. And when the patient presents with that active sort of hemorrhages all over, with a lot of hemorrhage in the disc, we are not able to see the cup disc ratio. And we of course go ahead with the injection. And vein occlusion, actually, as soon as the CRVO happens, the pressure drops. And that's what I think. I don't know whether Vijay ma'am and Rajul sir think like that.
Actually, eye with the neovascular element, the intravitreal injection helps. So whenever with the NVG, when we give the injection, it helps rather than it causes harm to the eye.
But I'm talking about fresh CRVO. There's no NVG as yet. But then we are not able to see the disc very clearly. And then we, at least I have not seen the disc too often. I keep seeing the macula. I think most retina surgeons are like that. And then after 3 or 4 injections, that kind of glaucoma started manifesting, where a lot of hemorrhages were clearing. And then I saw, oh, this is a very large cup. And that's when I actually ended up referring. So CRVO, it's not easy to see the cup, and therefore baseline glaucoma may be missed. So I think that is something that it's worth remembering.
So, sir, in such cases where you are not sure of the disc, do you start any, AGM before giving anti-VEGF?
So what I really do is, now I think about it all the time, and I do a paracentesis for most of these with CRVO, because I'm worried that there may be some underlying glaucoma, and I'm more sort of, focused on the disc at every visit, not only for these, but for all other patients, because I have
Right.
few patients, but then, this could happen.
So there is no harm in, evaluating, or if needed, start AGM for such,
Don't start AGM. Evaluate for glaucoma if there is in doubt. I think we are making, nothing out of this small risk. So evaluating glaucoma is important. So don't miss pre-injection glaucomas. So
Perfect, ma'am.
that is the take-home message, if you ask me.
Rajul, from your side, any take-home message from this article?
No, as ma'am said, we have to be very careful before, every patient. We have to examine thoroughly. Don't miss glaucoma before injection. Otherwise, and yeah, short axial length, risk of angle closure, do gonioscopy. The comprehensive examination must include gonioscopy. That is very important. So we don't miss angle closure.
Any other panelists who have any questions? So Vaishal or Dr. Joshi?
I think the whole presentation was made very lucid by madam, saying that this was just a transient rise in pressure, and the number of injections evaluating whether glaucoma is there, not there. And in glaucomatous eyes, you have to be more careful than the non-glaucomatous eyes. So I think we summarize and we thank. So I'll ask Dr. Rajesh Joshi to do the honors.
Yeah, we also have Dr. Sumit.
Radhika for good presentation.
Yeah.
Very nice
I
presentation.
just want to ask one question. Suppose if at all there is a intraocular pressure rise, which drug we should prefer for long term and for the short term? Is there any indication for any particular drug or contraindication?
Most of the retinal surgeons start with a combination drug for some reason. Combigan is the most favorite drug for them. So start with a single molecule, whichever you think is suitable for the patient.
We have Dr. Swapnesh Sawant also, who is a vitreoretinal surgeon. Any comments from him?
And
we have
one more thing I would like to add.
Dr. Sumit Lahane also. Yeah. Rajul, sorry.
If the patient is macular edema, then avoid prostaglandin.
Right.
The anti-VEGF is given for macular edema, then prostaglandin should be avoided.
Swapnesh, do you have any comment?
Yeah, madam. Can you hear me?
Yeah, we can.
Yeah. Swapnesh.
Yeah, it's an honor to talk in front of Vijaya, madam. And thank you all the senior panelists for giving me a chance. So as rightly put, in cases of intravitreal injection, in cases of CRVO and PDR, I definitely involve my glaucoma colleague. Whether the patient has a glaucoma or does not have a glaucoma, I want one visit with a glaucoma colleague just to have a review when the patient comes for follow-up, or even before that if I suspect that. But in cases of AMD, IPCP, vasculitis, post-op CME, where anti-VEGFs are required, usually that's not a part of the concern. And though this is not a part of the article, Ozurdex implant or any steroid given, that should raise your tentacles, that watch out for, and especially dislocated particles of sometimes the Ozurdex implant and sometimes IVTA crystals coming through the zonules or in aphakic patients in the AC. That should really raise the alarm bells that you watch out for glaucoma and have a more closer follow-up. What I do is in a busy OT where multiple injections are planned, just listen to the patient when he gets up from the OT chair or OT table, and I give my all injections under microscope. So most of these patients will give a clue as to this. The pain is not as usual, or their response is not as usual as the other. So don't hesitate to remove the patch and just put an indirect, and most of the time you will pick up that there is some issue. So that's my small bit. And in a post-vitrectomy, I usually that's not a problem. And as Sunny rightly said, if there is a egress, then most of the time the pressure is not going to be a problem at all. Thank you.
Yes, Swapnesh.
Perfect. Very nice tips.
So I think Vaishal, I think it's.
I think we are
Ragini ma'am,
good.
you want to say something? Fine. Dr. Sumit?
Yeah, Sumit is also there as the secretary of BOA. Swapnesh has already commented. So I think if both of them are, I think he's muted. Sumit?
Fine.
Ragini ma'am? I think. Anyway, they must be busy with the pre-conference thing. Nah?
Yes.
So I think on behalf of the Maharashtra Ophthalmological Society, Dr. Vijaya ma'am, and also Rajul to be here as this, and a very good presentation by Dr. What's the name?
Radhika.
Radhika.
Radhika. And Raksha madam, and of course, Vaishal, you are always there. Parul is there, and Dr. Sachin Agarwal. They've done a fantastic job. So I think we'll have the video of entered people for a minute.
Yeah,
before
Ragini ma'am
Dr.
has just joined. Ragini ma'am has just joined. Ma'am, concluding remarks, please, from your side. It's muted. Muted.
Thank you so much, Dr. Vijaya ma'am. Thank you so much for being with us. Thank you, Dr. Jignesh bhai. Thank you, Vaishal, and everybody, and Parul for conducting the series. And you are so dynamic. Sabya Sachi, Swapnesh, Sumit, Rajesh Joshi. I think Vijaya ma'am, Jignesh bhai is going to break a record. He has done, I think, 90
Today is a
webinars.
98 to 1. 98.
98.
So 100
98.
will be our quiz. We'll be celebrating it.
So thank you so much, everybody. Thank you, Dr. Sachin. Thank you.
Yeah. We'll have the entered video now.
Yeah. And then followed by the official Thanksgiving by Rajesh. Anmol, you can play the video. Yeah. Let's have the gallery view shot first. Everybody put the videos on. So that is for our posterity. We have this. Anmol, please take a gallery view shot.
Sure.
Yeah. Are you through?
Just give me a moment.
Yeah. Everybody, all the faculties, everybody, please put your videos on.
It's done.
You okay? Fine?
Yes, sir.
Yeah. Rajesh, over to you.
Yeah. That was really a wonderful discussion. And the essence of today's discussion is acute IOP elevation is common after anti-VEGF injection. IOP reducing agents should be considered in post-injection management, and pre-treatment with IOP reducing agent should be considered in high-risk patient, and close follow-up for IOP monitoring is essential in patients with pre-existing comorbidities. Thank you, Vijay Madam and Rajul sir, for highlighting on various aspects of IOP elevation after anti-VEGF injection. I thank Dr. Radhika for presenting today's topic. Radhika, you really presented well. Many thanks to coordinators for today's journal club, Dr. Raksha, Dr. Sachin Agrawal. Thanks, Sachin, for accepting invite at the last minute. Dr. Parul, Dr. Vaishal, and statistical experts, Dr. Sabyasachi, for valuable inputs. I'm also thankful to Office Bearers of BOA. Special thanks to Ragini Madam, President BOA, Dr. Sumit, Secretary BOA, Dr. Nikhil, Dr. Zain, Dr. Swapnesh for joining and giving valuable inputs. I'm also thankful to all those who have joined on virtual platform, and thanks to Entor for the technical support. Thank you all. Till we meet next.
Thank you. Thank you very much, everyone.
Right.
Thank you.
Thank you so much.
Thank
ma'am.
you. Thank you.
Thanks. You can stop the recording now,
Yeah.
Anmol.